Yeah, fall back too close, you ain't even know me. Trust my words from way back from the north. D&D.
Separate from talking about types of asthma, how asthma may change, and I talked in the intro a little bit about definitions of asthma and phenotypes and endotypes. I wanted to do one special section talking about the symptoms of asthma, because this is really important, because so much of our decisions come down to come down to what we're getting back from you guys in terms of reported symptoms. And so I think I just wanted to talk a little bit about the symptoms of asthma, right? And so it's important to understand, like I said before, asthma is a chronic condition, so it's got to happen over and over. So we're not talking about one episode of symptoms. We've got to talk about repetitive episodes of symptoms, and there's got to be periods usually in between where there aren't symptoms, or at least there's less symptoms. So there's variable episodes, and the symptoms that we typically see, by far and away the most common symptom is going to be cough, right? So that's, I think, very important to understand. Cough is the most common symptom of asthma. That cough gets described a lot of different ways. It's often described as dry, especially when you look in textbooks, and it certainly can be dry, kind of a repetitive. And it happens because there's cough receptors that line our airways. And sometimes bronchospasm and inflammation just by itself is enough to trigger this repetitive kind of bouts of coughing. But very often, depending on what's triggering it, whether it's allergen, whether it's virus, there's going to be an excessive amount of mucus. That's one of the other hallmarks, if you remember, of asthma, is that beyond inflammation, it's increased mucus production. So very often, this cough is going to be productive. In fact, very often when I'm talking to families and I'm either getting a history, like are there other people in the family with asthma, I might get the story of, well, no, nobody, but my cousin always has bronchitis, my uncle is always on antibiotics. And so unless you have an immune deficiency, you don't have chronic bronchitis. Patients with chronic bronchitis, most of the time, unless they're older and have COPD, have asthma. And so that productive cough, that sort of repetitive nature of it, where it's happening over and over, at least bouts of it, is very classic for asthma. So yes, dry cough, but often a productive cough that's repetitive, but very often, it doesn't get better unless you intervene. So you take albuterol, you change something about your environment, or but very often it's taking a rescue medicine. So sometimes if you're coughing because of just mucus, because you have a cold, you can sort of cough out the secretions and then you're fine. That's something different, right? This is a different kind of trigger. People talk a lot about wheezing, and wheezing is a symptom of asthma, but it's only one symptom of asthma. And this is important, is that it's something that we're going to hear with our stethoscope. It's not usually something that the parents are going to hear. And it happens from airway narrowing, right? Anytime we hear a noise, whether that noise is rattling of mucus in the chest, whether that noise is wheezing that we appreciate with the stethoscope, it's because there's turbulent airflow. And if you remember, when we talk about the lungs, think of a big upside down tree, right? The tree trunk, we branch to the right, we branch to the left, and then we branch 23 times. So lots and lots of smaller and smaller branches. And wrapped around those branches is smooth muscle. And so we can either have inflammation, the walls of those branches can become thick and inflamed. We can make more mucus, right? The mucus glands, one of the cells we call the goblet cell, can make more mucus. Sometimes that mucus can be very thick and that can get in the way of airflow. Or the muscles that are wrapped around those branches can squeeze. So all of those things can happen by themselves, or they can happen, what usually happen together, but that makes those branches more narrow, which causes turbulent airflow and the noises that we hear. But what's important to understand is that asthma affects the lung differently in different areas. So it's not like the entire tree is affected the exact same. Some of the branches are more inflamed, some of the branches have more bronchospasm, some of the areas have some of the branches have less of that going on. And it's caused by airflow. So the bigger the breath you take, often the more noise you may make. So we might have someone that we're listening, and at first we don't hear much, but when I ask them to take that big breath, that's when we start to hear the noises. And so often the wheezing and the noises of asthma are what we call polyphonic. It's musical. It sounds different every time the patient breathes. And that's really important, because that's one of the kind of keys when we're making that diagnosis. But importantly, what makes us even more worried is when we don't hear wheezing. And we don't hear wheezing because things are so tight, right? So if you're not moving enough air to even generate that wheeze, that's even more concerning. And so it's really important that the physicians, that the doctors listening, understand what normal breath sound should sound like, but also are really key to being able to tell, I'm not hearing, I have what we call decreased air entry. I don't hear enough air moving. That's really important because that's even more concerning. In fact, I'll have kids in the hospital that are very sick. You don't hear very much air movement. And as we get them back doing better, we start to relieve that bronchospasm. The inflammation is under better control. Now they're wheezing up a storm, and that's actually a good thing. And that's actually showing that they're getting better. And I may send them home with more wheezing because that's now showing that they're moving more air. And so the other one that brings in one of the other main symptoms, which is that work of breathing. So coughing, wheezing, and then dyspnea, increased work of breathing or chest tightness. So that may be the patient telling you, your child telling you, mama, it's hard to breathe. Dad, I feel like there's someone sitting on my chest. Or it may be that you look at them and they're breathing fast, they're breathing heavy. You see them tugging, right? That kind of tugging up here, or the tugging in between the ribs where you can see the ribs standing out because they're pulling so hard that they're sucking the skin actually in between each individual rib. That's called retractions, and that worries us, right? So that work of breathing, that sign of dyspnea, how hard or fast they're breathing is going to be very important as well. And so those are really the three most important signs and symptoms of asthma. And then as we give a medicine like albuterol, you want to see that get better. So once again, we said the wheezing part may not be something that you're appreciating, but you want to see, oh wow, that cough really slowed down, or ideally, man, that cough went away entirely. I gave the albuterol and man, they really started breathing more slowly. I saw those retractions go away, and that's really important. And then as we're following those signs and symptoms, if we give a treatment and we see improvement, that's great, and then we follow. And usually at home, we'll let you do the albuterol as often as every 4 hours. If it gets to be 4 hours, symptoms haven't come back, then that's fine. You don't give them more albuterol. You get to that 5th hour or 6th hour and that cough starts to creep back in, and you give them the albuterol. Now, if it's before that 4-hour mark, if it's been 2 hours or 3 hours, and man, that cough is coming back with a vengeance, that work of breathing is really kicking up, give the albuterol, right? I mean, that's important. Breathing is important, but that's a marker that I need to probably be calling someone, or we may need to go into the emergency room, urgent care, or go see the pediatrician. If we can't make it, 4 hours, if it's 2 hours, 3 hours, and we're having to give more treatments, that's a red flag. And so knowing those symptoms and what to look for and then what to expect in terms of treatment response is going to be really helpful when you're taking care of this at home.
Yeah, fall back too close, you ain't even know me. Trust my word is wrong, way back from the know me. It's me and the